Hello, if you're joining me here, we're going to be talking about the clotting disorders at this point. If you have not done the anemias and normal coagulation, go back and grab that piece of your, go back and watch that video before watching this one, because we do go over the normal clotting cascade and the normal platelet plug formation. We kind of go over the normals of all that in the anemia lecture. So grab that one first if you have not already. Once you've gone through the normals and the anemias, now you're here for the clotting disorders. We can talk about the thrombocytopenias. So what we're going to do is we're going to talk about thrombocytopenias. There are three kinds of thrombocytopenias, and then we're going to talk about clotting disorders. We have three kinds of clotting disorders. We have disseminated intravascular coagulation, we have hemophilia, and we have factor A7 deficiency, vitamin K deficiency. So we have three clotting disorders, we have three thrombocytopenias. So when we're talking about thrombocytopenias, we are talking about the platelets here, and we are talking about a reduction in platelet levels. So the platelets being below 150. Remember when I was talking back on the last lecture about the normals, we start to get worried about platelets when they drop below 150. So we're going to be looking at that platelet level, and all of these three thrombocytopenias have low platelet levels for various reasons. When you have low platelet levels, you are not creating the first line of defense and clotting. You do not make platelet plugs because you don't have enough platelets to plug up the holes and the damage. So when you don't have enough platelets, it does not mean you are completely bleeding all the time. You are just making small little micro bleeds that then do clot off once the clotting cascade works. So with thrombocytopenia, usually the clotting cascade is still functional. It's just that the platelet plug is less than adequate. So with thrombocytopenias, you get microbleeding, spontaneous bleeding without any injury that you know about to yourself. Vessels are constantly being damaged by things circulating around in them and brushing up against walls and kind of breaking vessel walls. But we don't have those first line of defenders, the platelets to plug up the hole, so they bleed for a little bit until the clotting cascade comes and clots up the hole. So you end up with like little microhemorrhages, these little tiny petechiae, little tiny areas of bleeds. Bruises, purpuras are a cluster of small petechiae or small circular dots that are tiny bleeds that have stopped. You might end up with gum and nosebleeds, or more frequent nose bleeding. You may find yourself bleeding from gums spontaneously. When your gums get scraped up by food, they have little microbleeds, and usually platelets stop those right away. You could have blood in your urine. That is a finding that when you don't have platelet plugs, the nephrons are constantly being damaged by toxins, and some of those could leak blood that they don't have platelets around to plug them up. So a little bit of blood in the urine, large bruises, those are from larger bleeds. So those are what we're seeing when we don't have our platelet plugging. Of course, if your platelets drop too low, you could have large-scale bleeding, evidence of GI bleeding. You could have strokes in your brain if you have damage to one of your brain blood vessels that doesn't get plugged up. You can bleed into your brain. So those are worsening cues of a thrombocytopenia, are GI bleeds, hemorrhagic strokes, and large-scale bleeding. So the three kinds, we will talk about what makes them specific, but when we're talking about the key symptoms, you're seeing purpuras, petechiae, and ecchymosis. You're seeing bleeding gums, bleeding nose, any variations of those, you might have a platelet disorder. We are monitoring, basically everything is normal except for your platelet count. I don't think I put all those. You just have a reduction in your platelet count. Your PTT are normal. Your fibrinogen level is normal. Fibrin breakdown products are normal. Hemoglobin, hematocrit are normal. You are having bleeding, but they are micro bleedings, not enough to drop your hemoglobin hematocrit unless you are in a worsening condition. So you want to keep an eye on the amount of bleeding, the areas you're seeing bleed on the surface, just basically checking for any kind of blood. So, but the key of these conditions is that you're seeing a low platelet count. So let's talk about the three kinds and what makes them specific. You have an immune thrombocytopenia purpura. Now, this is a big, long name for a very easy disease. The immune system's eating your platelets. So you have platelet production, but they get destroyed. So you have a thrombocytopenia, meaning you have a low number of platelets circulating around, and that causes petechiae and purpura. Purpura means large areas of small microbleeds. So this is due to the destruction of platelets. You have a decreased platelet count. You have your coagulation times are normal because your clotting cascade is not affected. Your fibrinogen levels are normal. Your amount of clotting in your body is normal. So everything is normal except for the fact that you have microbleeds, and that is due to the fact that the immune system is attacking your platelets for some reason. What do you do to stop the immune system from attacking the platelets? We do steroids. We talked in the immune lecture that we do not like steroids for a long-term care of patients. So they get switched pretty regularly. What they're going to do is they're going to go on a round of steroids to see if that solves the problem. If the platelet count goes up on steroids, then they say it's an immune disorder, it's an autoimmune disease, your body's attacking your platelets for some reason. So the drug of choice for this is, I don't even know how to say that, rituximab. Anyway, it is a chemotherapy medication, but it reduces the immune recognition of platelets. So just because it's a chemotherapy medicine doesn't mean that you have a cancer. It's just a med that they have found works in decreasing the immune recognition of platelets and stops the immune system from attacking platelets. So if it responds well to steroids, they're not going to leave you on steroids for your life because of the increased risk of high glucose levels and Cushing's syndrome. If they don't leave people on steroids, they will switch you over to ritomixicab. Anyway, chemotherapy, I can't even say it. But that is the medication for long-term use of immune thrombocytopenia. And if for some reason the platelet count has dropped so low that it's less than 10,000, so that's a platelet count of 10, not a platelet count of 100, a platelet count of 10. If your platelets are completely gone, they can give you platelet transfusions, or if bleeding is anticipated before a procedure, they may give you an infusion of platelets. Otherwise, we will try to reduce the immune system targeting the platelets with the chemotherapy medication that I cannot say the name of, or a splenectomy will actually remove the antibodies to platelets. The antibodies are carried on your B and T cell lymphocytes, the white blood cells that are responsible for immunity. And so if you remove the spleen, it will decrease the amount of antibody-producing white blood cells that are there, and they could reduce the number of attacks on the platelets. And usually this is caused, again, most autoimmune diseases are triggered into a flare-up by stress, illness, hot, cold. So basically we'll try to reduce the flare-ups of ITP, and you'll be on long-term therapy with a low-dose chemotherapy medication. So it's not like you're going on full-on chemotherapy. It's a very low dose of a medication, and its purpose in this case is to reduce your immune recognizing of platelets. It kind of hides the platelets, hides them. I don't know how, but it does work, and it does reduce the number of flare-ups that you have where your platelet count drops. So anyway, that's immune thrombocytopenic purpura. It's an autoimmune process, gets autoimmune meds. Thrombocytopenic purpura, thrombotic thrombocytopenia has two different problems. We have the thrombocytopenia, so you have a low platelet count, but this is caused because the immune system is not eating platelets. The immune system has, or actually the factor there, this von Willebrand factor, is a protein that roams around in our plasma, and this factor is abnormally large. There is a protein that kind of breaks down this factor into smaller pieces that we do use. Anyway, it is a protein, this factor is, and when the protein doesn't get broken down, it makes these long chains that that are sticky to platelets, and the platelets get all activated by these Willebrand factors. Now remember, when platelets are activated, they're one and done. Once they become sticky, they get used up. So because these large von Willebrand factors are circulating around in our bloodstream, and platelets are attracted to activate by these long chained factors, the platelets get all activated and clump up on top of these von Willebrand factors and create a clump called a microclot. So not only do we end up, you have normal levels of platelets, but they get super activated, and when all of your platelets get activated, you're left with no actual unactivated platelets, which is actually a reduction in useful platelets. So the ITP creates just microbleeds, and those are your signs and symptoms, our little microbleeds, petechiae purpura. TTP has microclots along with your microbleeds. So your microbleeds is the von Willebrand factor activating and using up all the platelets. The microclots are this area of tissue necrosis, very similar to sickle cell anemia. Areas of tissue necrosis due to, now they're not sickled cells causing the clots in the arteries, but they are the von Willebrand factor and all these activated platelets sticking to it. So this is a picture here of what these von Willebrand factors in their useful conditions are supposed to be teeny tiny little guys. In this disease, the von Willebrand factor that the body, I do believe there are cells that make this von Willebrand factor, they don't get broken down, and they're these giant chains that attract and activate platelets. So platelets stick to these long chains of von Willebrand factor and make microclots. So these microclots end up blocking blood flow, and so we end up with ischemia on this end. They usually get stuck in small capillaries, just like sickle cell anemia. So anyway, blood is flowed. So the clotting cascade still works. This does not affect the clotting cascade. It only uses up platelets. It activates and uses up platelets. So you get microbleeds because of lack of platelets. So you get clogging in certain areas of the vessel, and you have blocked blood flow that causes ischemia. So what you see is a mix of tiny microbleeds. You have petechiae purpura bleeds, and then you have areas of tissue necrosis. And that's what you can see on the hand down here. These are the petechiae and the little areas of hemorrhage here. And then these are areas of tissue necrosis where it's been blocked and the fingertip has actually lost its blood flow to the fingertips from these microclots. So anyway, microclots, microbleeds are the keys of TTP. There is some element of lysis going on here as the red blood cells are working their way through. I don't know if you can see, let me clear my little things here, but you can see the red blood cells getting lysed as they try to pass through the clot here. These are lysed cells here. So the red blood cells get lysed as they pass past the clot here, and that causes the hemolytic anemia as well. So TTP is not that great during a flare-up. You have a lot of microclots, a lot of microbleeds, and you have a hemolytic anemia. There's also some neurologic manifestations. Again, this is kind of an autoimmune disease as well, but it is not attacking platelets directly. What it's doing is it's attacking the thing that is supposed to be breaking down these von Willebrand factors. So it is an autoimmune disease, does cause a low-grade fever, does cause these little microclots in your brain and in your eyes. You do have visual disturbances, numbness, tingling, various signs, so very much more serious than ITP, TTP, both of them, and autoimmune, but it's an inappropriate activation of platelets by these von Willebrand factors that didn't get broken down. So if you see von Willebrand factor associated to TTP And thrombotic, thrombocytopenic purpura has a decreased platelet count. Again, the coag times are normal, but your fibrinogen levels and your fibrin breakdown products are higher because there's a lot more clotting happening here, because now not only are the platelets being activated, but now the clotting cascade is putting fibrin mesh on top of all of these as well, and creating a lot bigger clots that then need to be broken up. So we're using fibrinogen to make these fibrin meshes, and then this clot needs to be broken down. So eventually the body will break down these clots. There's just a lot of them all over the body. So unlike ITP, which just eats up the platelets and you don't have platelets, but the body is not creating junk that then gets clotted over. The body is just basically saying, well, the platelets didn't do their job. I'm going to go over there and fix a damaged area. So there's not an abnormal amount of clotting going on, but during the thrombotic, which means a thrombosis, which means a clot, thrombotic, thrombocytopenia. So you have clotting and low platelet count going on at the same time. Somebody will ask me, how is that different than DIC? And I will tell you in a moment. So this is microclotting and microbleeding going on at the same time, TTP. What do we do with TTP? Well, we try to avoid the triggers that are causing a flare-up. Serious illnesses, injuries, pregnancy, infections can all cause a flare-up. Because clotting is involved in this one, not anticoagulants, but basically clot prophylaxis, low-dose aspirin, low molecular weight heparin, things that you would do to prevent clotting. We want to prevent, if this is happening, we want to keep blood flow going through here. We want blood flow going through here. We don't need a giant fibrin mesh forming on top of this. This is not a damaged vessel that needs to stop bleeding. So we want to block that clot forming on top of this big clump of activated platelets. So because there is clotting or thrombosis going on, that it is appropriate to give a prophylaxis for clotting. So a low-dose aspirin will help the platelets not respond to the von Willebrand factor, because remember, aspirin is an antiplatelet. It prevents the platelet from activating and will not allow for these setups. So low-dose aspirin is a very helpful antiplatelet. Low molecular weight heparin will be on, that if you do have these thromboses forming, they won't create a giant clot that then blocks the circulation. Aggressive hydration, again, there's some element of hemolytic anemia here, so hydration will keep those things flowing through, keep them from clumping up and causing ischemia, and bleeding precautions for those microbleeds. Plasmapheresis is if you are having worsening cues, meaning you are having organ ischemia, or worsening tissue ischemia and increased bleeds. Plasmapheresis will physically exchange your plasma. It's a plasma exchange. It is done on a dialysis type machine. You do not need dialysis access. But what they're doing is they take out your plasma and replace the plasma. When you get plasmapheresis, it is a huge amount. I went to go pick up plasma for plasmapheresis, and they gave me 30 bags of fresh frozen plasma, because you are replacing the body's plasma with new plasma, because it's going to remove the lysed red blood cells, it's going to remove those activated platelets, and you want to put them back. Plasma is replaced with, it says another solution such as saline or albumin, but you can replace it with other plasma as well. So they basically take out the plasma, remove your own plasma, and put plasma back into the body. They can supplement it so you're not using so much fresh frozen plasma that they will supplement it with saline and albumin. But basically they will plasma exchange daily until the platelet counts stay normal and there is no more clotting and bleeding going on. But this is a very invasive procedure, plasmapheresis, and it is saved for worsening cues. So if you are having small microclots, microbleeds, they will treat those with aspirin, heparin, and aggressive hydration. If you are having large, extensive bleeding or having signs of organ failure, then they will do plasmapheresis, which is a highly invasive procedure where they're just exchanging out all those activated platelets until they can get the trigger under control and stop this whole process from happening. So plasmapheresis for worsening cues. The third one, so we have immune, which is basically your immune system eating up platelets but doesn't cause any other problems. That one is treated with steroids and an chemotherapy medicine. TTP is thrombosis and thrombocytopenia happening together. We're much more worried about our renal function, our kidney function, our brain function, making sure that everything stays cleared, and avoiding extra thromboses with aspirin to prevent the activation of platelets, with low molecular weight heparin to prevent any further clots from getting too big and causing ischemia. If we miss the window and ischemia is caused and organ damage is happening, then we will do plasmapheresis. Heparin-induced thrombocytopenia is exactly what it's called. It is called a heparin allergy. Heparin is causing the inappropriate activation of platelets. So this is very similar to TTP, but TTP's cause is the von Willebrand factor, whereas the heparin-induced thrombocytopenia is due to heparin causing the activation of platelets. So there are two kinds. The mild one we don't really worry about. The platelet count drops. They get super activated, but there's no other signs and symptoms. The platelet count drops, but then comes back in 3 days when your bone marrow makes more. The worst kind is pretty rare. I've only seen extensive or severe hit probably 2 or 3 times in my career. But it's where basically the patient develops what looks like thrombocytopenic purpura, or TTP, but they've never had any history of it in their life, and they have had a history of heparin in the previous week. If you've had heparin in the previous week and you are coming up with TTP symptoms, which is microclotting and microbleeding, they will call it heparin-induced thrombocytopenia and say you have an allergy to heparin. The only difference in from this to TTP is that there's no hemolytic anemia that goes along with it, so you don't need to worry about the aggressive hydration and organ failure, but they still do. The platelets get used up, cause microbleeding, and the sticky platelets that are activated do cause microclotting. So again, your platelet count is going to be decreased because they're all being used up and activated. Your coagulation times are not affected, and there is more clotting going on. So your fibrinogen levels are low, they're being used up in the clots, and your fibrin breakdown products are higher because there's more clots to break up. So just a disease of the platelets, but this one is caused by heparin. And what we're going to do is we're going to stop heparin. Just like with any allergy, we're going to stop it. Unfortunately, this happens 4 to 10 days after heparin is given. So sometimes the patient has already had a huge dose of heparin by the time their allergy is noticed. But permanently stopping all heparin, including heparin flushes, put the allergy on the medical record. It is an allergy. Put it under the allergy system. Put heparin allergy, history of heparin-induced thrombocytopenia needs to be put on the record so the patient does not get heparin again in the future. We do have a thing called protamine, which reverses heparin. I don't know if you learned about that anywhere in your history, but if this patient was getting heparin as an anticoagulant, and now all of a sudden they are clotting and having microclots, that's a sign of HIT, because with heparin you shouldn't have microclots being formed. But if you are having a heparin allergy, and because this patient's probably been getting heparin for a couple of days before the allergy shows up, they may give protamine sulfate to reverse any circulating heparin and stop this process from happening. In the meanwhile, because microclots are happening, low-dose aspirin is a good idea to reverse it, to stop any activation of platelets. Low molecular weight, oh, that is not appropriate. I just copied that from the previous slide. That is not appropriate. Remove that from the slide. Low molecular weight heparin could be causing this problem. So that is not appropriate. We would want to remove that one. If you have a heparin allergy, you're not taking low molecular weight heparin. You're not taking any form of heparin. You're going to be on a low-dose aspirin to prevent the activation of platelets. People will say, well, if you're on heparin, should you be on aspirin too? Well, heparin is affecting our clotting cascade. It does not affect our platelets usually at all unless you have an allergy to heparin. So low-dose aspirin is okay. One, to prevent the activation of platelets from any leftover heparin that is circulating, and two, to continue whatever anticoagulation might be needed by heparin. They can go on Coumadin, they can go on warfarin, they can go on another kind of anticoagulant, but just not heparin. And again, if the heparin-induced thrombocytopenia is so severe that organ dysfunction is happening, then plasmapheresis is on the table. But it is a very invasive procedure, only used for worsening conditions. Let's talk about the clotting cascade disorders. So those were just the platelet disorders, the thrombocytopenia. We have immune. We have TTP, which is due to an immune response to von Willebrand factor. And we have heparin, an immune reaction, an allergy to heparin. So those are the three kinds of thrombocytopenia. The first one, the immune one, does not cause microclotting, just causes microbleeding. The other two, TTP and heparin-induced, cause microclotting and microbleeding. And TTP has an extra added problem of hemolytic anemia with it as well. So we're going to look at the clotting cascade disorders. And the first one is the dreaded, always talked about, disseminated intravascular coagulation. And people are thinking, well, TTP is pretty bad. Unfortunately, the disseminated intravascular coagulation isn't just a platelet problem. It's an autoimmune response to a severe illness. So basically our immune system gets a little bit jacked up and decides to go and fight everything, not just the illness. And it actually ends up activating not only your platelets, but it activates your clotting cascade as well. And they are seeing this is what is happening in some patients with COVID. They are having disseminated intravascular coagulation, and the disorder of DIC and how it differs from TTP is that TTP had microclots and microbleeds, so did heparin-induced thrombocytopenia, microclots and microbleeds, but because the coagulation cascade is also being damaged in DIC, you get major clots and major bleeds going on. So this is a completely inappropriate reaction and shuts down both our clotting system and our platelet system. So what happens is that you end up using up, so we activate the clotting cascades. So when you activate the clotting cascades, what are you making? You're making huge clots all over the body. The clotting cascade is activated inappropriately. It is now being activated all over the body, not just where there is damage. This tissue factor goes in and stimulates both clotting cascades. You use up all your clotting factors, you use up all your fibrinogen, you make these great fibrin meshes all over your entire body. Large fibrin clots everywhere, not just over damaged parts, but just everywhere, in organs, in the brain, in the heart, in the lungs, in blood vessels. Fibrin clots are everywhere until there are no more clotting factors anymore, and then the clotting factors, the clots all live everywhere, all over the body, but there are no more clotting factors left. Everything has been used up. The fibrinogen has all been used up. There's clots everywhere, and now any bleed that does spring up is going to bleed unfettered. So major clots, major bleeds from the the activation of clotting cascade, the activation of platelets. Those sticky, large platelets are all over the body, getting microclots everywhere. So you have microclots, micro bleeds, major bleeds. Everything is bleeding and clotting all over the place. It is a worsening condition. Microbleeding, large hemorrhagic bleeds, they can be anywhere. They can be bleeding in the lungs. You can have bleeding in the GI system. You can have bleeding in the brain. And on top of that, large-scale clots, large fibrin clots everywhere. DVTs, PEs, MIs, strokes. So you can have a hemorrhagic stroke and a thrombotic stroke at the same time on these patients. You can have bleeding lungs and PEs at the same time. You can have GI bleeds and obstructed bowel vessels at the same time. It is a mess. The factors, the platelet count is decreased because all the platelets got used up. The coagulation times are increased. Remember, with all the thrombocytopenias, our coagulation times, your PT, your PTT, your INR were normal. Here they are all increased because the clotting cascades are all used up. So your clotting times end up increasing. It's taking forever to clot, or you're not clotting at all because you've used up all your fibrinogen. The fibrinogen levels are decreased. They were all used up in clots. The fibrin breakdown products, we still have our natural TPA that's going around trying to clean up this giant mess. And the fibrin breakdown products are huge because you have huge fibrin clots all over the body to clean up. It cannot clean up fast enough. So what do you do for DIC? Everything is out of control. Your clotting cascades, you've got clots everywhere, you've got bleeding everywhere, you've got major clots, micro bleeds, major bleeds. They're everywhere. The only thing we can really do is try to treat the underlying disorder that is causing this giant flare-up. I've added COVID-19 to it because COVID-19 is one of our triggers now for DIC. Sepsis, cancer, trauma, all these things can cause DIC. And it's really just kind of a bad luck card, really. You don't know who's going to be more prone to things like adult respiratory distress syndrome, who's going to be prone to things like DIC. We don't know when your immune system's going to go haywire until it happens. Some people with sepsis do never develop DIC. Some people with sepsis develop DIC. There's no rhyme or reason at this point to who is more prone to this autoimmune disorder. But basically, it's inappropriate activation of clotting and platelets. Because they're bleeding, we're going to have bleeding precautions. Really, the only treatments for this is to try to hydrate the patient through and try to get these clots moving, keep them circulating, keep them from plugging up and causing tissue ischemia. We need to give blood products. Because you're having major bleeds, we're losing red blood cells. Because we've used up all our clotting factors, we need to give plasma because FFP has clotting factors in it. So we're going to give platelets, we're going to give clotting factors, and plasmapheresis is the best way to give these blood products. If we just dump red blood cells and FFP and platelets into the situation, we still have all these old used up products running around in our bloodstream. So plasmapheresis, again, this is a worsening condition. It is the treatment for DIC. We go in there and we clean out the plasma and replace it with functioning plasma. They can have red blood cells with it as well. So what you're going to see in a DIC panel is that they're going to look at your PT, your PTT, your INR. They're all going to be elevated because there's no more clotting factors left, so your clotting times are prolonged. Your platelets are all used up. Your platelet counts are low. But your fibrinogen is also low because it got all used up, and your fibrin split products and your fibrin degradation products are high. But basically the difference between DIC and TTP lab-wise is really the difference in your coagulation studies. So when we go back and look at TTP, you can see our platelet count is decreased because they're activated. Your fibrinogen levels are up because there's some clots, or your fibrinogen levels are low because there's more microclotting going on. The fibrin split products are increased. Those labs are all the same, but your coagulation times, your clotting cascade is okay in heparin-induced thrombocytopenia and in DIC. So they're both disorders of too much clotting and too much bleeding, both TTP and heparin, but or heparin-induced. But if you look at these, our platelet count is decreased, our fibrinogen levels are decreased, and the fibrin split products are increased. Those are all the same, but in these thrombocytopenias, your coagulation times are normal. Your PT and PTT and INR are normal. So that is the one big difference between TTP, HIT, and DIC, is DIC has, yes, decreased platelet count, yes, decreased fibrinogen, yes, fibrin split products, yes, that's all the same, but now we have our coagulation system involved. So this is the big difference between DIC and TTP and HIT. So TTP and HIT are pretty serious, but there can be a milder form that, maybe we don't need to do plasmapheresis with. Maybe we'll just get rid of the underlying cause, monitor it. If they have worsening conditions, plasmapheresis. But in DIC, it's already a worsening condition, and plasmapheresis is indicated for DIC right off the bat, whereas plasmapheresis is only for worsening conditions of TTP and HIT. I hope that makes sense. These are not easy topics. They're not easy to think about, but I wanted to explain it to you the best I can. Hopefully this is helpful. Hemophilia is a disorder of the clotting cascade and clotting cascade only. Your platelets are working just fine. You have no problems with your platelets. Your platelets are normal. And your PT, one of your clotting cascades. So with hemophilia, you're only involved in one of your cascades. With classic hemophilia, or most of the hemophilias, they're over here in the intrinsic pathway. So this intrinsic pathway is measured by PTT. And so your PTT, your clotting times from that one pathway are increased, but your PT and your platelets are normal. So this one is working just fine. Your platelets are working just fine. It's just this one cascade that is knocked out because you're missing one of these factors, so it can't cascade down. So basically what you're seeing is your first line of defense, your platelet plug, works. Your second line of defense basically half works. This extrinsic pathway still works. So you kind of got a little duplication of effort in here. So you're not having a complete shutdown of your clotting cascade, just a partial shutdown of your coagulation cascade. There are a bunch of different kinds. You don't have to memorize which ones are called which ones. Just know that with most hemophilias, you are measuring these by the PTT, and you will get a factor assay which determines which clotting factor is missing for you. Worsening cues are just multiple bleeding episodes causing big bleeds or destruction of the cartilage. But again, really the major things I want you to remember about hemophilia, and if you have any kind of hemophilia, whether it's hemophilia A, B, or C, it's just a missing factor. And so what do we do to treat it? We give you your factor back, whatever factor you are missing. They can replace factor 8, factor 9, you can replace all these factors. What they do is they spin it out from human plasma. They spin it out and turn it into a concentrate that is given IV as an outpatient. So if you are hemophiliac, you will probably go in for an outpatient treatment every maybe month or so to get your factor replaced. The big treatment is preventing bleeding episodes, making sure they know what bleeding precautions are. And there is a medicine that will work. And the most common fact, I think I wrote the commonality here. No, I didn't. Hemophilia A, this one's called classic hemophilia. This is like 80% of the population with hemophilia has hemophilia A. Hemophilia B, I do believe this is 15% of the population, and hemophilia C was 5%. And it's not that important, but factor 8 is the most common hemophilia. And so they have created basically lab produced, just like we kind of have lab produced insulin now. You don't have to get regular human insulin. If it's called recombinant, it just means it's produced in the lab. But they do have factor 8 and factor 9. But either way, they get their factor replacement. If you have classic hemophilia, there's 2 other medicines that you can use. The gold standard is the clotting factor concentrate. So just remember to replace the concentrate. And really, any question I'm going to ask you on hemophilia is going to probably involve in like, what are you going to do for your patient? You're going to give them their clotting factor concentrate replacement. So whatever clotting factor is missing, they need to get that clotting factor replaced to them. There are a couple of meds that are off to the side. Again, these 2, and this one sounds like the same med. I can't say it. Those MAB meds, the chemotherapy meds. This one actually replaces, I don't know how, magic, I guess, I don't know, replaces the function of factor 8 rather than replacing it, reduces the frequency of bleeding episodes. So you might recognize that one. I'm not going to test you on it, but maybe you come across it in a prep you question or something like that. And DDAVP, which is antidiuretic hormone that we just learned about in the endocrine lecture, antidiuretic hormone has a couple of other off-label uses, and one of them, for some reason, it increases the concentration of factor 8, so that can help a patient. But really, I want you to remember these. I don't want you to really focus on the alternate things, just in case you recognize them somewhere, that they are alternate therapies for hemophilia. And Amicar is an acid that basically keeps clots from breaking down. And so once you get a clot, it doesn't break down as quickly. But again, those are all recommended by a physician. The main replacement is replacing your clotting factor. I'm not going to spend too much time on all the rest of them. The other clotting disorder that we had, so we have the DIC, which is platelets and both coagulation cascades trashed. Everything's trashed. The hemophilia is the intrinsic pathway, and then factor 7 vitamin K deficiency is the one that affects the extrinsic pathway and your prothrombin times. This one is just called usually vitamin K deficiency because the inherited factor 7 deficiency, fewer than 200 documented cases in the world, very rare. But you can acquire factor 7 deficiency because you don't have enough vitamin K. Vitamin K is known as the clotting vitamin, and it actually, we use vitamin K to make clotting factor 7. So you need vitamin K to make the extrinsic pathway work. So when you are weak on your vitamin K or you have a vitamin K deficiency, then you have problems with the extrinsic pathway. So this one usually comes from, like I said, a vitamin K deficiency. Long-term antibiotic use can cause a vitamin K deficiency. Chemotherapy medicines can cause a vitamin K deficiency. Of course, we learned about the liver disease and cirrhosis. You don't store your vitamin K. And in sepsis, you don't have as good bowel perfusion, so you don't absorb vitamin K. So if you are lacking on your vitamin K and you start having bleeding episodes, nosebleeds, bleeding gums, unexplained bruising, heavy periods, you might need to up your vitamin K dose. But the difference between this one is that the increased lab values are going to be your PT, INR, because we're measuring your extrinsic pathway. On the hemophilias, those were measuring your, the hemophilias were your increased PTT because it's your intrinsic pathway. the vitamin K deficiency is your PT-INR and your extrinsic pathway. So if you have a patient with hemophilia, type A hemophilia, giving them vitamin K isn't going to do anything. They never had problems with that pathway at all. So if you put vitamin K, oops, Lord have mercy, I'm trying to draw, and it's all over the place. If you give, vitamin K is here involved in factor 7. If you are missing factor 9 and you give them vitamin K, you're beefing up the extrinsic pathway, but you're not doing anything to make this pathway work. This pathway will continue to be gone until you give factor 9 or factor 8, whichever one you're missing. Basically, this pathway cannot continue if you're missing one of the factors. So with hemophilia A, the treatment is not going to be giving yourself vitamin K because it's not going to help. Vitamin K only works if your PT-INR are increased. So the more you know. Sometimes when your PT-INR is increased, or if you learned that maybe you give vitamin K if you want to have an antidote to Coumadin, or you're not supposed to take vitamin K if you're on Coumadin, that's because Coumadin works here in your extrinsic pathway. So Coumadin is going in here to block factor 7. And it's blocking this pathway so that you don't coagulate as well, right? We're giving you Coumadin for a reason. So if we go in there and Coumadin is blocking factor 7. So if you eat a ton of vitamin K, guess what you're making? You're making factor 7. And then your Coumadin dose doesn't work because you ate tons of vitamin K. So you may see a lot of prep you questions on if you're on Coumadin, don't eat vitamin K because you're just basically overriding what Coumadin is supposed to do. Coumadin is supposed to slow down this pathway. It's supposed to increase your PT-INR, and it's supposed to keep you from clotting. And then if you go and eat a ton of vitamin K, it makes a ton of factor 7, and your Coumadin dose is no longer going to be effective. So there is a relationship between vitamin K, clotting, and Coumadin, but it only works on that extrinsic pathway, which is where Coumadin works. Heparin works over here. Heparin works over here in these two pathways. So we measure heparin with PT-T, and we measure Coumadin with PT-INR. But again, I'm not going to test you on all that. I just want you to realize that there is a relationship here between vitamin K and factor 7. And if you don't know the Roman numerals, I put the 7s next to each of the Roman numerals because apparently you don't teach Roman numerals in school anymore. My kids never learned Roman numerals, and medicine's real big on the Roman numerals for the cranial nerves and all this stuff. So they don't get, you don't learn that anymore. But vitamin K goes with factor 7. Vitamin K helps produce factor 7. So if we're trying to anticoagulate with Coumadin, vitamin K is going to counteract our anticoagulation of that. Just a little fun fact. But if you have a vitamin K deficiency and you are bleeding, you're not on Coumadin, and you are bleeding from your extrinsic pathway not working, then eating extra vitamin K or giving yourself a vitamin K supplement will create factor 7 and help you get that extrinsic pathway back on track. So when we are trying to figure out which pathway is in trouble, we will look at our PT-INR, and that will tell us what factor is somewhat involved. So if your PTT is elevated, we don't have a vitamin K deficiency. We have a problem with factor 8, 9, 12, whatever factors are all in there. Factor 7 is over by itself on the extrinsic pathway. So if your PT-INR are increased and you're not on Coumadin, they may want to look at giving you vitamin K. And especially if your vitamin K level is low and your factor level 7 is missing, they will try to get you some potassium. Or not potassium, oh my God. Vitamin K is not potassium. Vitamin K is its own vitamin. So we're going to either give you factor 7 concentrate replacement or vitamin K supplements. They'll probably try vitamin K first to see if that helps your factor 7. If for some reason you have malabsorption, maybe you don't have a good intestine, then you can get the concentrate replacement. You can give vitamin K as an actual sub-Q IV supplement. Comes in a little glass vial, and you can pull it out and give it as an IV supplement. You can put it in IV fluids. You can also eat vitamin K rich foods. So vitamin K rich foods will help you create factor 7, but if for some reason your bowel absorption is no bueno and you can't absorb all these yummy tasty foods, or maybe you have sepsis and your bowels aren't working that great, and you can't eat, or you're NPO, then you will be getting your vitamin K supplement sub-Q or IV. IM is not recommended. It comes with a lot of side effects, but giving vitamin K sub-Q or IM will increase your factor 7. So most patients that end up with a prolonged PT-INR, a normal PTT, and are not taking Coumadin, the source of the problem is probably vitamin K deficiency. So that is anticoagulation in a nutshell. I'll let you go back, reread, rethink, rewrite your notes. It is hard to keep them separated. Let me know what I can do to help you. We will be doing Cahoots in class to help you sort these things out. But like I said, go back and try to sort them all so they make sense to you. And let me know if you have questions.